Kul Bahadur is selling his cattle. Ramakrishna is giving away his land in exchange for a loan. Lakshmi is calling her son, who is working abroad. Sita is selling her jewelry. Among several others, Kul Bahadur, Ramakrishna, Lakshmi and Sita are gathering money to pay medical bills. Our health sector is mired with various problems: infrastructure, quality of care, response time, etc. But the major problem that is yet overlooked is how the health sector is financed. 21% of the health financing comes from the government, 18.5% from the external development partners, but the largest share is from the people of Nepal, 55%. Out of national budget, about 5% is allocated to Ministry of Health. Out of this amount, over 90% goes to the Ministry of Health, while the rest is allocated to other ministries. Majority of Nepali population is forced to pay out of pocket in exchange for health services. Meaning, a person paying for health services out of pocket would be paying for it twice, from direct bills and also through taxes. This, in some cases, leads to catastrophic spending, which leaves people economically vulnerable and also open to risk of additional diseases. A lower income family might end up spending a significant amount of their assets compared to the higher income families, further increasing inequities among income groups. Direct and indirect taxes, non-tax revenue, and external development funds make up government revenues. 74% of the costs are spent on medicines and 19% on the fees. This, added with the taxes, places a significant financial burden on the poor. Furthermore, a significant difference of medical costs exists between geographical regions, genders, and development areas. But aren't these government subsidies and free services for financially vulnerable families? Yes, but the financing system is equally disjointed and in dire need of reform. The way government financing works is through allocation of funds into different headers and topics, quantitative rather than qualitative. The Ministry of Health takes the role of pooling agent and distributes the assigned budget to different institutions and levels. In theory, this works. Delegation of work should increase efficiency. However, the funding streams get highly fragmented by the time financing arrives to the districts and health facilities. Take the facility in rural Nepal, for example. The health facilities receives funds from a number of different centers, divisions, programs, and local bodies. However, they can allocate a fund only for a specific program or treatment rather than the facility as a whole. If a patient comes in with an illness that is being subsidized by incoming funds, they will receive treatment. But if they come in with multiple illnesses, they will be forced to pay for the treatment of the uncovered illnesses out of pocket, leading to financial burden. As the budget is mostly expense-based rather than the quality of care, there is no way to actually gauge the need and the quality of health facility itself. This is not a problem of a single facility, but of the Nepali healthcare as a whole. In the absence of fee structures, regulations, and with an outdated financing model, people end up spending a lot of money on healthcare. The line item-based budgeting leads to a lack of flexibility, and the focus ends up being on a specific care package only. This line-based budget is mostly outdated and often leaves the most vulnerable patients in the dust. Additionally, funding comes to easier access areas. Truly remote areas often end up being left in the dust, adding lack of access to an already long list of problems. Though there is an ample effort in creating a better health sector, the implementation method is highly outdated and needs a reform. The emphasis needs to be on the quality of care rather than the line items and programs. The pay out of pocket model needs to be discouraged for a better and more progressive system in order to ease the financial burden of the poverty-struck households. People are not line items, and health is an incredible resource that we take for granted. The health financing system must make a move towards becoming more streamlined, more personable, and more transparent to ensure the ones needing the care are being cared for. This is the present. Let's change it into a better future.